Hello, my name is Luis Dickman. I'm a psychiatrist here in Brazil, and today I have the great honor to interview Professor Denis Huremovic, who is the Director of Psychiatry at North Shore University Hospital. Thank you for coming, Professor.
Muito obrigado. Thank you for having me. It's a pleasure to be with you.
Now we are going to talk about depression. So, Professor, could you tell me more about the neuropsychiatric signature that the pandemics can create?
Yes, so that is something that we talk about when we talk about uh, infectious diseases, or let's say, viral illnesses. We all, for example, know how the herpes virus can cause encephalitis, and how HIV affects the brain, and it causes subcortical dementia, and so on and so forth. So when the first reports started emerging that COVID-19 also, can cause encephalitis and neurological issues, people started to panic. And there was a lot of sensationalist articles that came out basically saying, are we going to see people with neuropsychiatric sequelae lasting for years and decades and disability and so on? And again, that sensationalist approach serves nothing but to disseminate panic and anxiety. It does not help people. So when you look at COVID-19, for example, so far, and compare it to other viral diseases, particularly other coronaviral diseases, there is not that much difference. Sometimes they can cause encephalitis. They, of course, can cause delirium, some rare complications like ADEM, and so on. And of course, the most frequent ones are loss of smell and loss of taste. And that's basically the most kind of terrible one that everybody, or most people, 1 in 4 will have experienced. But if we are going to talk about neuropsychiatric issues, then I think at this point it's best to start thinking about COVID-19 about as a vascular disease, not only a respiratory disease, because it affects the way affects the coagulation in such a way that it can lead to blood clots in different areas, including the brain, and lead to strokes and other deficits. And so that's something that you're going to see more likely than, let's say, some other issues that you can, for example, see in Ebola, that can really plague people and give them a lot of time to recover cognitively and physically. Most people, vast majority, recover without lasting effects. Some people, of course, will have longer lasting effects, and that is, the group of people that we have to try and help. And again, I think that when we think about the long-term consequences, neuropsychiatric consequences of COVID, then we have to start thinking about the inflammatory processes, not just an acute illness. And the question is, does COVID-19 trigger certain inflammatory responses that linger in our body for months and maybe years? And that's what makes people both depressed, having pains, being weak, and having so-called cognitive fog that some people report in the wake of COVID-19.
So we are talking about this kind of problems. About depression, Professor, what do you think, how we can make the difference to our colleagues between the major depression disorder and the depression symptoms that anyone can feel in that times of pandemics and things like that, everything closed and jobs being lost, life being devastated, healthcares are overwhelmed and burnout, things like that. How we can differ what is psychiatry, what is a normal situation?
It's a great question, and I think we have to go by what ICD-10 or DSM-5 tell us, and that is that major depressive episode really is associated with profound impairment of functioning and considerable symptoms. Now, it may be difficult to tease out something that we can call adjustment disorder to this situation versus real depression. versus post-traumatic stress that some COVID survivors may experience, because you are forced to sit at home, you have lost your job, or you don't know how you are going to continue working and supporting your family. That is already a loss of functioning. So that is already impairment in functioning. How you can really make this distinction is how, based on how much a person is affected on the inside in terms of their mentation and in terms of their mood. And if they're really depressed, and if it goes on for weeks, and it's associated particularly with issues of guilt and cognitive processes and helplessness, hopelessness, and even suicidality, then yes, that's a depression that needs to be treated. If it's something more alongside the lines of what the general population feels, you probably are better off by not putting patients on medications, or actually not patients, individuals who may be complaining. But as I said in the last, in the previous response, our role is dual. One is to treat, and the other one is to be beacons of hope and kind of to project this optimism. People sometimes ask you, not with an intent of getting a medication from you, but they approach you because they think you know so much more than they do, and they want to hear that everything's going to be all right in the end.
And about the health workers, what do you think? So 2 years ago, your book was being going to the public. 1 year ago, the pandemic was growing. So we have the lockdowns and things like that, including USA, that was the most affected one. What do you thought would being this full year? Do you think it's happening what you thought would happen? Do you think it matches about the theory and the practical things that happens in these 4 years?
Well, some things did match, some things didn't. It kind of depends on how you look at it. I think that at least in my organization, which is Northwell Health, I was fortunate enough to have leadership that was perceptive to some of the suggestions that we came up with in the book. And, it's not really, I'm not being really smart here. Those suggestions are kind of intuitive, and it boils down to several major points. One is give people personal protective equipment. In other words, you want to protect their mental health, well, you have to protect them. So if they don't have masks, if they don't have respirators, if they don't have other stuff, they're going to panic, they're going to freak out, and yes, they're going to develop PTSD and depression. So that is number one. Number two is make sure that whatever you tell people, whatever guidelines you have, that you don't change, that they're very clear, that everybody knows what they're expected to do, and that you don't change them every 15 days or 5 minutes, because that drives people crazy. They, when you make a change, you say, I'm sorry, we have to do it this way now because we have, learned something new, and this is going to help save lives. The third thing is that you want to have an open channel of communication with your personnel. If you're the boss, your people have to be able to get back to you and tell you, listen, what you told us is not working, or listen, we learned something new. So when people feel that they are being heard and that they are being protected, and the fourth point is when they feel that they have good colleagues to work with, that's an enormous protective factor against PTSD. And so whoever implemented some of these elements has profited handsomely from their personnel not developing PTSD and not being traumatized. That is, for example, that has been our lecture. Something that I did expect was this vaccine hesitancy. We knew that people will have trouble accepting the vaccine, particularly some people in the United States, because they feel like you are imposing on their individual liberties. So we knew that. What I didn't see was that people will have the same attitude about the illness itself, that there will be a whole bunch of people, millions of people, or worldwide, probably north of 1 billion people telling you, COVID does not exist. It's all made up thing by some political this or by Bill Gates, and that is the part that I kind of didn't anticipate. I was surprised.
Yes, it's a shame that nowadays we have so much, and some of our colleagues even think like that. So it happens. Nah, I think everybody that watching us here don't think like that. But we've seen a lot of things that happens that we didn't uh, thought it would happen in 2021. So let's make a question about depression, how it was and how are the incidents now after 1 year of COVID-19. Did the population raise it that have depression? Did it's stable? What was and what is now? Do you know how to answer that, Professor?
I actually don't have the exact data because studies are still being done. What we do know, however, is that if there is depression, a lot of this depression will really stem from the anxiety associated with the situation. We know, for example, that in Hong Kong at the outbreak, so about a year ago, a significant proportion of population had symptoms of anxiety and depression, even if they were not directly affected by COVID-19. So it is absolutely reasonable to expect that rates of depression and anxiety will rise in general population. It is also reasonable to expect that the relapses will be seen in our existing patients with both disorders of anxiety, depression, and also some other ones such as serious mental illness and substance abuse. We also know that you see anxiety, depression, and insomnia as the kind of triad of symptoms or syndromes in people who survive COVID-19, and that's kind of close to, on average, 30%. So yes, you will see an increase in depression across the board. General population, your existing patients, COVID survivors, and healthcare personnel.
What about treatment, Professor? We have patients, we have individuals, we have to separate them, which one is normal and which one is pathologic, and how do we treat them?
Excellent question. So if you have people who are presenting with mainly symptoms of what we could call adjustment disorder with, let's say, mixed anxiety and depression, and that's the general population that previously didn't have depression, then you are better off by using either supportive therapy or CBT or short course of anxiolytics, hoping to help them overcome short-term issues. And only if you think that it's necessary, then the standard of care would be to use antidepressants such as SSRIs. I think the similar answer would be, or the next kind of challenging step would be your pre-existing patients. Your pre-existing patients who you already treat now may need to have their medications tweaked. You may have to increase the dose. You may temporarily have to add an anxiolytic medication, or you may have to add a different antidepressant with a different mechanism of action, or you can add a low dose of an atypical neuroleptic to kind of augment that effect. So those are pretty much your standard issues when it comes to treating depression. When it comes to treating depression in COVID-19 survivors, I think a lot of that is associated with the inflammatory processes. And so I think, this is going to be a gold mine for us in terms of finding out what is going on and how does it affect our brain. And so all the issues that we see, inflammatory markers, IL-6 or TNF, various gene expression that happens for example, 2x families and so on of receptors that you studied as well. All that will come into place, and we'll learn a little bit more. What can we do now? For now, I think it helps if we skip the SSRI, serotonin reuptake inhibitors, and move straight to SNRIs, and even consider the use of, let's say, tricyclics, because they may be more helpful when you have an inflammatory process associated, even monoamine oxidase inhibitors, or sometimes even stimulants. But I think the first line of treatment for COVID survivors would be serotonin, norepinephrine reuptake inhibitors, and tricyclics.
Oh, perfect. I like your approach on psychopharmacology. Perfect. Professor, in your clinic, in your day-to-day life, what are you seeing in your patients? That one that was a COVID survivor, and another one that didn't have the infection. The rates of incidence in your day-to-day life raised or stay the same?
I think that the incidence probably raised somewhat, but I don't have any hard data to say, and so I kind of don't know what figures will come up with, but yes, the data changed, and then I very often get only the most complicated patients. In other words, people who are just struggling and have never had COVID and they don't have previous mental illness will not reach me. So I don't know if their primary care physicians are helping them with medications, but the ones that are, for example, COVID survivors and have had protracted hospital stay and had issues of traumatic experience, that is difficult to treat.
Professor, in depression, some of our patients, I have seen a high number of them, are complaining about something that we call the cognitive fog. That's it's hard to understand, to read, to think about, to make calculations, to work. They think they are not working as they were before. So do you have something to say about that? How to identify, how to treat this? I know it's a difficult question because of the papers, but what do you have to say in your opinion, Professor?
It's a fantastic question, and that is probably the issue that we are going to be struggling with for the next couple of years. But I think there is also an opportunity for us to learn from that, because as I said, I think a lot of these neurocognitive effects that we are seeing could be a likely combination of vascular and then inflammatory effects that happen as a function of endothelial inflammation that happens in vascular and blood vessels throughout the organism. So people, among other things, experience a little bit of difficulty concentrating, a little bit of memory loss, and all these are fairly soft deficits, but they can sometimes be identified with the use of simple tools such as a MoCA, for example, or a mini MMSE. And so that gives you a little bit of an idea when someone is really struggling. The point here would be that if someone comes with you with those complaints, you should not necessarily discard them as, oh, you're just hypochondriac and so on and so forth, that those things can be real and are real. There is going to be a tremendous work ahead of us to kind of try and understand how the inflammation and then the use of anti-inflammatory agents can address this issue. For example, we have now opened the door to use agents such as IL-6 antagonists, which would be sarilumab, or otilimab, which is a GM-CSF antagonist. And by being a granulocyte macrophage colony stimulating factor antagonist, otilimab, for example, can intercept inflammatory processes in 4 different ways. So by blocking interleukins, by blocking T cells, and so on. So maybe by using some of these agents, or I know that there are other pathways, like, for example, X2R7 receptors and their antagonists, but we don't have an approved substance yet. We have some that are being tested. So we will learn a lot, and that will lead, I think, to advancements in neuropsychiatry, possibly transplant psychiatry, neuroimmunology, and even, tumors, because a lot of these neoplastic formations in the brain actually respond to similar signals. So by blocking them, we can help stem the growth of these neoplastic formations. In order to find your way out of this mess, I think it helps you as a provider to conceptualize, first of all, who is the population that you're working with. And so you have to kind of, we have maybe touched on it a little bit, but you have to understand whether you're dealing with the general population, whether you are dealing with people who already had some sort of mental illness and now are struggling with COVID, the whole situation, whether you are dealing with people who are COVID survivors and their family members, or you're dealing with healthcare personnel and frontline staff members, or it could be a combination thereof. But once you know who your patients are, what group they fit in, then it's easier for you to basically come up with the response. I think the only issue here that we don't know much about is COVID-19 and depression. And as I said, you probably want to go and address the inflammatory issue early head on by using something that either has norepinephrine affinity, such as SNRI or tricyclics, or something that can be a little bit stimulating. So sometimes people use let's say monoamino oxidase B inhibitors such as selegiline, or stimulants such as modafinil, armodafinil, or real stimulants, amphetamines, just to get those patients who have just survived COVID-19 out of the funk and show them that they can regain their energy and their panache in life. So that would be the point is you have to expand your line of thinking. When it comes to both COVID survivors and healthcare personnel, you have to think about post-traumatic stress disorder. You have to, but you cannot assume. So again, you have to really ask about their experiences, what happened, what did they see, how did they feel. We know that people who have been intubated, for example, and that's a very high percentage of people who end up in hospital for COVID-19, about, let's say, 1/4 to 1/3 of them will have PTSD, because having something being shoved down your throat and then breathing for you is very, very traumatic. It's a very intense sensation of panic. So that is going to be perhaps one of the challenges that we will be seeing in the months to come. Also, people who worked, healthcare personnel who worked with all the patients, having to see all those patients gasping for air, having to triage and say, well, this one cannot be helped, let's focus on the other one, or having to call the families and tell them that their loved ones had died, all the while being afraid that they are going to get sick and maybe die, or get sick and infect their loved ones and their family members. That's a tremendous burden, and that's something that has a potential to cause PTSD in a lot of frontline workers and healthcare personnel. So we have to be mindful of that possibility.
Thank you, Professor. Thank you very much for this kind of conversation.
Thank you very much for having me. Muito obrigado. And I hope that by next time my Portuguese is going to be better.